Thank you very much. Hi. So today I'll be discussing the common complications of chronic endocrine diseases with a review of the underlying pathophysiology and how the influence of these diseases influence management and also surgical complications. Z-Medica is a wonderful partner to complement this subject as they have in-clinic blood analyzers called TrueForma, which can detect low TSH concentrations in hyperthyroid cats with normal T4 as well as quantitate canine cortisol, endogenous ACTH, and a complete in-clinic thyroid diagnostic panel. Chronic endocrine diseases affect an estimated 1% of middle-aged dogs, about 11% of cats, and they can have profound influences on surgical complications, critical care outcomes, and prognosis. We'll be discussing the pathophysiology of common complications underlying hypergenocorticoism, diabetes mellitus, hyperthyroidism, hypothyroidism, and hypoadrenocorticoism, as well as highlight specific parameters we monitored, and also go through and discuss how these complications can arise and influence treatment and surgery. So hypergenocorticoism, which is my favorite endocrine disease, is a chronic pathological overproduction of cortisol due to oversecretion of adrenocorticotropic hormone by a functional pituitary tumor or the consequence of adrenal disorder, and rarely ectopic secretion of ACTH, and less commonly also from the diet. In dogs, there's an estimated incidence of approximately 0.2%, with pituitary tumors accounting for 80 to 85% of these cases. In cats, hypergenocorticoism is rare, with 100 or less reported cases. And pituitary-dependent hypergenocorticoism is most common, accounting for approximately 80% of feline cases. Adrenal-dependent tumors compose less than 20%, and less commonly, adrenal sex steroid-producing tumors can also cause clinical signs. The clinical signs we most commonly see of this disease include obesity, a pendulous abdomen due to hepatomegaly and muscle atrophy arising from increased gluconeogenesis, inhibition of protein synthesis, and atrophy of type 2 of the fast twitch muscle fibers. Dermatological changes are a common clinical sign with skin atrophy, alopecia, hyperpigmentation, as well as an increased risk of pyoderma. Thirst can also be increased due to decreased urine concentrating ability and the effects of a pseudodiabetes insipidus condition that develops in pituitary hypergenocorticoism, in which macroadenoma compresses the posterior lobe of the pituitary and extends into the hypothalamus, causing disruption of the antidiuretic hormone. These clinical signs are attributed to an increase in excessive secretion of cortisol. Increased cortisol causes an increase in circulating glucose through hepatic neogenesis and hepatic glucose output and hepatic fatty acid synthesis, which collectively contributes to hepatomegaly. Decreased pancreatic insulin secretion and peripheral insulin resistance and decreased uptake of glucose by skeletal muscle results in muscle weakness and contributes to hypoglycemia that is further enhanced by lipolysis and decreased lipogenesis in adipose tissue, as well as decreased glucose uptake. Together, the metabolic shifts from chronic cortisol secretion shifts metabolism from glycolysis to ketosis and fosters the formation of a metabolic syndrome characterized by abnormal lipid metabolism, insulin resistance, hypoglycemia, and increased appetite. Elevated cortisol redirects hepatic glucose metabolism towards gluconeogenesis, with subsequent glycogen production and storage of hepatocytes, impairing their function and damaging liver cells, which can be characterized by a release of ALT, either due to small little blebs being given off by the liver cells, or by overt apoptosis of the liver cells. Biocaniculi can become overwhelmed and clogged as cortisol promotes lipogenesis, and subsequent hypercholesteremia as adipose is broken down, and uptake is impaired through a decrease in LDL liver receptors and decreased liver metabolism. And glucocorticoids can also induce an expression of alkaline phosphatase isoenzyme, which can influence liver metabolic function and biometabolism. Chronic elevation of cortisol impairs insulin function through direct effects of cortisol and secondary to chronic hyperglycemia. Cortisol can directly suppress insulin release from beta cells and glucagon from alpha cells in the pancreas, and cortisol also impairs glucose uptake in smooth muscle tissue by inhibiting expression of insulin receptor and the insulin signaling pathway. Chronic hyperglycemia is further perpetuated through cortisol-mediated hepatic gluconeogenesis and adipose lipolysis, and inhibition of glucose uptake in adipose tissue. Studies in human medicines and also in dogs with chronic congestive heart failure and sepsis, they found that hyperglycemia is associated with a higher risk of mortality, hospitalization, and increased infection rate. And hypergenic cortisone insulin resistance and chronic hyperglycemia, they can lead to diabetes mellitus. About 8 to 16% of fishing rate dogs go on to develop diabetes. And management of these dogs' glucose and Cushing's clinical signs can be challenging as they have higher insulin requirements, and they also have higher trialostine requirements. And in the study by Perez Lopez, they show that dogs that have Cushing's disease as well as diabetes mellitus have significantly shorter survival time, whereas the dogs with only diabetes or only with Cushing's disease. Interestingly, dogs with a blood glucose less than 105 milligrams per deciliter at the time of being diagnosed with Cushing's disease and treated with a low dose of Decamir, a long-acting insulin analog, in addition to treatment with Cushing's, were less likely to develop diabetes mellitus. This suggests that there's a component of beta cell exhaustion in these cases. In terms of beta cells, they aren't able to go through and be able to keep up with the demands of insulin production. Hypergenocorticism contributes to hypercoagulability through an increase in procoagulant factors 8 and also von Willebrand factors, as well as increased fibrinogen and decreased fibrolysis, predisposing to the rapid formation of stable thromboemboli. And the chronic inflammation within the vessels due to the effects of hyperglycemia leads to irreversible endothelial damage. And thromboemboli can form in pulmonary veins, splenic veins, the aorta, and iliac arteries. Evaluation of Cushing rate dogs with thromboelastography or TEG, which is basically used to go through and assess how quickly clots are formed, the strength of the clot and how quickly it's broken down. K represents the initial onset clot formation. The alpha is going to go through and be able to represent how quickly the actual clot will be formed, and the MA shows how strong that clot can be. Dogs with Cushing's disease, they have a decreased kappa, so they form clots very quickly, and also an increased alpha angle, which means these clots are formed very fast, and also increased MA, which means these are very strong clots that are being formed. And this thromboembolism can develop in dogs with well-managed Cushing's disease. In this study, they went through and looked at dogs, measured them by TEG, as well as other parameters of coagulation, and they found before starting treatment with trialostane, as well as after 3 months of trialostane, and also after 6 months of trialostane treatment, these dogs didn't have any change in their overall alpha, kappa, or MA measurements. So hypercoagulability can persist despite treatment with trialostane. Neurological signs can arise due to pituitary tumors compressing the optic nerve and optic chiasma, meaning blurred vision, compression of the medial temporal lobe, or obstruction of the third ventricle leading to seizures. Pituitary macroadenomas can also cause pseudodiabetes mellitus with associated polydipsia due to compression of the posterior lobe of the pituitary and also extension into the hypothalamus, causing disruption of antidiuretic hormone. Calcification, secondary to hyperglycemia, and subsequent atherosclerosis of the iliac arteries. And so these arrows are going according to the iliac arteries, and the iliac arteries are more apparent because they have calcification within that. And that can go through and cause pelvic lymphoresis. And dogs that have calcification of iliac arteries, they're weak in the pelvic limbs, and they have difficulty walking, or they're not able to walk, yet they retain intact general proprioception and withdrawal reflexes. A substantial number of Cushing rate dogs have subclinical urinary tract infections in which they can present without clinical signs. In this study, they found that less than 5% of dogs had clinical signs associated with urinary tract infection. These clinical signs include what we commonly see, which is polyuria, stranguria, plaqueuria, and also discolored urine. However, of these 46 to asymptomatic dogs, 46% had positive urine cultures. There's several underlying reasons why dogs with Cushing's disease can be at increased risk of developing urinary tract infection. And that's due to cortisol-mediated immunosuppression, the hyperglycemia within the bladder itself can make them prone to developing urinary tract infections, as well as muscle weakness, allowing for the bladder to become overextended and urine retention. Doing E. coli is the most common bacteria isolated. Yet there is a small percentage of dogs with Cushing's disease, and they do have clinical signs suggesting a urinary tract infection, but they don't culture positive, because there's actually due to them having these clinical signs of these clinical signs are actually due to renal etiologies such as glomerulosclerosis or pyelonephritis. Hypertension, which is defined as systolic blood pressure greater than 140 milliliters of mercury by the 2018 ACVIM consensus statement, is a common adverse effect, which is prevalent in 70 to 82% of Cushing-like dogs. It's believed to be a multifactorial mechanism in which excessive levels of circulating cortisol saturates the 11-beta hydroxy steroid dehydrogenase enzyme, which converts cortisol to cortisone, resulting in excess circulating mineralocorticoid, which then goes through and influences increased tubular sodium reabsorption and potassium secretion. As sodium binds water and retains within vessels, intravascular volume expands and can lead to hypertension. Glucocorticoids active also the renin-angiotensin-aldosterone system, further increasing sodium reabsorption and water absorption. And elevated circulating levels of cortisol also decreases production of nitric oxide synthase, which catalyzes the production of nitric oxide, a mediator of venodilation, and the decrease in nitric oxide leads to arterial vasoconstriction. Systemic hypertension is not associated with plasma or urine cortisol levels. It increases the risk of thrombocytosis by contributing to endothelial dysfunction by increasing shear stress on small blood vessels, and also increases expression of procoagulant factors such as platelet activated factor, leading to activation of the coagulation cascade and an increased risk of thrombus. There's also hypokalemia due to sodium retention, hypoxuria due to water retention, and proteinuria in dogs with Cushing's. Treatment alone with trilostane does not consistently resolve the hypertension, and the blood pressure medications, as the ACE inhibitor and or amlodipine, may be needed for adequate blood pressure regulation. Dogs with Cushing's disease, they're at a very high risk, about 20 times more likely for the development of gallbladder mucocele. The underlying mechanism for the increased risk in Cushing-like dogs is not very well elucidated. However, hyperadrenocorticism can increase anesthetic and surgical risk during cholecystectomy, including hypertension, impaired respiration due to weakened respiratory muscles, an increased risk of pulmonary thromboembolism, and altered acid base and electrolyte imbalances, as well as delayed wound healing and increased risk of post-surgical infections. Monitoring of Cushing-like patients during anesthetic procedures, as well as during hospitalization, should include vigilant monitoring of glucose levels, blood pressure, urinary tract infection with a urine culture, skin infections, and the development of neurological signs, including acute blindness, as well as progressive changes in liver values. Certain drugs, the dexdomitor, which causes reflex hypertension, should be avoided if possible, and fluid should be carefully adjusted to reflect urine production as water retention may occur. Diabetes mellitus occurs in both dogs and cats, with the prevalence in the feline population reported to be about 0.25 to 1.25%. And type 2 or insulin-resistant diabetes mellitus occurs in about 80% cats. In contrast, dogs have a similarity to type 1 diabetes in humans, or insulin-deficient diabetes, which occurs in about 0.25 to 1% of the canine population. Diabetes mellitus caused by either insulin deficiency or impaired insulin secretion leads to reduction of glucose utilization, which prompts a change in metabolism from glycolysis to ketosis. And the energy is derived from peripheral fat with an increase in lipolysis. Protein from muscle is broken down. The liver and kidney function can be overwhelmed by the elevated ketones and hyperglycemia, leading to diabetic complications. Pancreatitis is a common adverse effect and occurs in about 28 to 40% of dogs with diabetes mellitus based on histopathology at necropsy, and is attributed to the glucotoxic effects of chronic hyperglycemia, as well as the toxic effects of hyperlipidemia, creating pancreatic inflammation that damages beta cells and also causes a systemic pro-inflammatory state that damages target tissues of insulin and causes insulin resistance. In cats, pancreatitis is found in about 51 to 57% of cats with diabetes mellitus on histopathology at necropsy. The progression of inflammation is broadly similar in both species, as hypoglycemia promotes inflammation within the pancreas and progressive destruction of the isolate of Langerhans and subsequent impaired function of beta and alpha cells. In both species, chronic pancreatitis leads to a diffuse fibrosis and lymphocytic inflammation, and the ability of the beta cells to renew and regenerate has been implicated as a major factor in the development of diabetes and pancreatitis. Although diabetes and concurrent pancreatitis can impact quality of life, additional factors such as the age of diagnosis, concurrent diseases, being an unspayed female, prior glucocorticoid treatment, and certain breed types impact diabetes survival times more than concurrent pancreatitis. Urinary tract infections are common, with about 13% of diabetic cats and 14 to 37% of asymptomatic dogs with diabetes having positive urine cultures. Chronic hyperglycemia impairs the immune system and causes glycosiduria, which facilitates bacterial proliferation in the urinary tract that can lead to pyelonephritis. Renal failure can also arise as hypoglycemia damages glomeruli and also blood vessels in the kidneys, which can impair the kidney's ability to filter waste products and increase stability to pathogens. The severity of renal injury correlates with systolic blood pressure, glycemic status, and also the duration of diabetes. Infections are a common complication in diabetic dogs and cats, as hypoglycemia impairs the immune system, which can increase the risk for pyometra. There's an increased risk for surgical site infections in diabetic dogs with a reported incidence of 3 to 8.7%. And this can increase the time of wound management as well as development of antibiotic resistance. A diabetic cardiomyopathy is recognized in dogs and cats, is characterized as a diastolic dysfunction with left ventricular wall thickness that can arise within 1 year of the start of insulin treatment. This development is independent of glycemic control and arises from multiple mechanisms. This includes progressive decay of intracellular calcium due to alterations in expression of calcium-associated proteins that can alter cardiomyocyte contraction. There's also impaired fatty acid and ketone metabolism, which is the diabetic heart's primary source of metabolism, and the metabolism of fatty acid and ketones can be impaired, particularly in times of stress and hypoxia. Also, there's upregulation of cardiomyocyte hypertrophic associated genes by advanced glycation end products and accumulation of reactive oxygen species that damage the myocardial vasculature. Over time, these cumulative effects can progress to myocardial hypertrophy and fibrosis and eventually heart failure, yet most cats and dogs do not live long enough for diabetic cardiomyopathy to progress to heart failure unless there are underlying heart conditions are present. In dogs, there's markers of cardiomyopathy such as NT-proBNP and cardiac troponin are not present are not elevated within 1 year of diabetic treatment. However, you can go through and see left ventricular wall thickness suggested on echocardiography, suggesting this diastolic dysfunction. Treatment of heart disease with diuretics can also lower potassium levels, and it can further impair beta cell insulin release and the peripheral effects of insulin resistance. So ocular changes, particularly to the lens, retina, and ocular surface, are common in diabetic dogs. Cataracts occur in about 80% of diabetic dogs within 16 months of diagnosis, yet occur less commonly in diabetic cats due to the lower level of aldose reductase. Canine cataracts develop as excessive glucose in the ocular fluid enters the lens and is converted to sorbitol by the enzyme aldose reductase. Sorbitol attracts water into the lens, causing swelling and disruption of lens fiber, creating the characteristic cloudiness of cataracts. This process is accompanied by oxidative stress and damage to lens proteins. And diabetic dogs are more likely to have postoperative complications following phaco emulsion, including corneal ulcers, diffuse corneal edema, lipemia, aqueous humor, and also ocular neuropathies. Ocular surface disorders, such as tear film disorders, ulcers, infections, and polyneuropathies, are common complications in diabetics. Schirmer tear test can be decreased, and this is not due to a decrease in actual tear production, but is indicative of a decreased reflexive tear response. Diabetics are twice as likely to develop dry eye at 2 weeks post-phaco emulsification, and small dogs, less than 10 kilograms, are approximately 2 times more likely to develop dry eye than those that weigh more than 10 kilograms. Lens-induced uveitis is common in diabetic dogs and occurs in 71% due to protein leakage from the lens, inducing an inflammatory response to the anterior chamber. And canine diabetic retinopathy occurs at high glucose levels greater than 180 mg/dL, and severe hypertension can damage retinal blood vessels, leading to leakage and retinal swelling. The new blood vessels that form, they're fragile, and they're prone to capillary microaneurysms, hemorrhages, retinal detachment, and vision loss. This damage can be reversible depending on the severity following glycemic control. However, retinal hemorrhages can occur in diabetic dogs post-phaco emulsion, about 21% being affected. Diabetic neuropathies, including sensory and autonomic polyneuropathies, as well as cranial nerve palsies, are common. These neuropathies occur more commonly in cats than dogs, and cats can present with plantigrade posturing, subtle muscle weakness, neurological deficits, and muscle atrophy. Whereas dogs can develop chronic and progressive kind of limb weakness that can progress to tetraparesis and tetraplegia. Broadly, these diabetic neuropathies can arise due to microvascular diseases and mitochondrial dysfunction that causes Schwann cell dissociation and disruption of the myelin sheath, axonal loss, and degeneration. These mild neuropathies can resolve with good glycemic control over several weeks to months, whereas more severe cases may need physical therapy. Corneal ulcers can arise due to decreased corneal sensitivity, causing a blunted blink reflex, and neuropathies can also cause pain due to generation of peripheral nerves, creating a lower threshold for nerve activation and subsequent hyperexcitability. Anesthesia for diabetics should consider anesthetic drugs that influence glucose levels, as well as hydration and electrolyte balances. Dexmedetomidine inhibits insulin release that can exacerbate hyperglycemia. Ketamine's sympathomimetic effect can lead to an increase in circulating glucose, and opioids can decrease appetite, which can confound insulin administration. Diabetic patients are more prone to fluid and electrolyte imbalances due to osmotic effects of glycosuria, as well as GI upset, including vomiting, diarrhea, and decreased water intake. Diabetics have an increased risk of surgical site infections relative to non-diabetics, and careful monitoring of the surgical site incisions and catheter or other insertion sites can help go through and detect early evidence of infection. Loop diuretics can inhibit reabsorption of sodium and chloride in the ascending kidney, leading to increased potassium secretion in the urine, and hypokalemia can develop, which can impair beta cell insulin release, as well as the peripheral effects of insulin, which can further exacerbate the hypoglycemia. Monitoring diabetics in the hospital and after discharge should include monitoring for dry eye, corneal ulcers, and uveitis. A chair supplement rather than a chair stimulant should be used following anesthesia procedures, as chair production may normalize within about 2 weeks. Careful monitoring of ingestion of fluids of control of vomiting and diarrhea, and monitoring the surgical and catheter sites carefully for evidence of infection, which may include checking temperature and possibly CBC, and monitoring glucose levels routinely and adjusting insulin appropriately. Hyperthyroidism occurs in both dogs and cats with a differing etiology. Hyperthyroidism in cats is most commonly caused by benign adenoma that can overproduce thyroid hormones. This occurs most frequently in cats that are older than 9 years old, with an incidence of about 11%. And most common causes of hyperthyroidism, the incidence of 2.5% is thyroid adenocarcinomas and rarely thyroiditis. Dogs rarely develop hyperthyroidism, as the primary cause is thyroid adenocarcinomas, which represent about 1.2% of all tumors that occur in dogs. And of these, 10% are actually functional, in which they secrete functional thyroid hormone. Other less common causes include overdosing of medications for hypothyroidism and consumption of raw diets containing tissues with high levels of thyroid hormone, as well as supplements. Thyroid hormones affect many organs of the body, producing a myriad of complications involving kidneys, central and peripheral nervous system, cardiovascular system, GI tract, liver, and muscle. Thyroid hormones can negatively affect cardiovascular and renal function, and this is caused by thyroid hormones, causing relaxation of vascular smooth muscle cells and decreasing peripheral resistance up to 50%, leading to an increased cardiac output. The increase in cardiac output increases renal blood flow, glomerular capillary pressure, and increased GFR. Thyroid hormone contributes to increase in GFR directly by increasing absorption of chloride in the proximal tubule, and that decreases the chloride in the distal tubule, which when sensed by the macula densa, further increases GFR by dilating the afferent arteriole and constricting the efferent arteriole, and also increasing sodium resorption. Upregulation of ROS contributes to restore effective arterial filling volume by further increasing sodium reabsorption. This increase in GFR can mask underlying kidney disease. And many cats develop chronic kidney disease approximately 1 month after becoming euthyroid hyperthyroid treatment. A low GFR prior to I-131 treatment confers a poor prognosis, as there's a significant reduction in functioning nephrons in hypothyroid cats, and most of these cats can develop renal failure within 30 days of treatment. Similarly, a low USG prior to hyperthyroid treatments is a sensitive but not specific indicator for the development of chronic kidney disease post-hyperthyroidism treatment. Thyroid hormones upregulate beta-adrenergic receptors within the cardiac tissue and renal cortex, increasing sympathetic activity and further increasing the ROS activity, contributing to an increased cardiac output of 60% or more. The cardiac effect of thyroid hormones is reversible, causes a reversible hypertrophic cardiomyopathy. It's relatively common in hyperthyroid cats, yet the prevalence and severity has decreased due to earlier diagnosis and treatment. About 50% of these cats have a heart murmur at time of diagnosis. The most common clinical findings are tachycardia, systolic murmurs, Gallup murmur, and less commonly arrhythmias. On echocardiography, the most common abnormalities include left ventricular hypertrophy, thickened intraventricular septum, and myocardial hypercontractility. Treatment for hypothyroidism resolves or improves the cardiomyopathy, yet treatment for cardiomyopathy may be needed depending on the severity. Congestive heart failure second to hyperthyroidism is not common. Sarcopenia is a common clinical finding that occurs as hyperthyroidism induces a catabolic state associated with increased energy expenditure, increased lipolysis, and increased protein turnover, resulting in loss of body weight, decreased body fat storage, and lean body mass. Following normalization of thyroid hormone, muscle mass is restored before the fat deposits. Hypothyroidism can occur in cats 6 to 9 months after receiving a tailored regime of I-131. Overdosing of I-131 resulting in hypothyroidism can significantly increase the risk of azotemia developing. And in this study, 74% cats reported to be euthyroid, and of these, 12% became azotemic after receiving a tailored dose of I-131. Subclinical hypothyroidism developed in 17% of cats, and of those, 39% became azotemic. And overt hypothyroidism developed in 4% of cats, with 70% of these cats becoming azotemic. And azotemia is associated with a lower survival time in cats relative to non-azotemic cats. Thyrotoxicosis has been rarely reported in veterinary medicine, yet in human medicine, overt thyrotoxicosis has an occurrence of about 0.5% of people in the US, and a mortality rate of 25%. It occurs secondary to a precipitating event that causes a rapid rise of circulating thyroid hormone, which can affect the cardiovascular system, pulmonary, and GI tract, resulting in tachycardia, hypertension, and increased end-tidal CO2. Possible main causes include thyroid surgery, vigorous manipulation of thyroid, infection that can decrease circulating proteins that bind thyroid hormone, ingestion of exogenous thyroid hormones, and radioactive iodine therapy. A few case studies in veterinary medicine reporting thyrotoxicosis reported severe metabolic and respiratory acidosis, postoperative congestive heart failure, hypertension, GI upset, hypokalemia, and muscle tremors. Thyroid storm is a clinical diagnosis, however, there's no diagnostic test available for identification or confirmation. Similarly, there's no scoring system for potential thyrotoxicosis in veterinary medicine, and the Birch-Rokitansky scale has been used in prior veterinary case studies, which have been adapted from human medicine. This rubric is a numeric severity scale of risk factors for toxicosis, including fever, CNS effects, GI upset, hepatobiliary signs, and cardiovascular signs. Monitoring ECG, blood pressure, and blood gas routinely during anesthesia and recovery can promptly alert to the development of abnormalities. Prior to performing anesthetic procedures, normalization of T4 can circumvent thyrotoxicosis, and the treatment for thyrotoxicosis includes antithyroid therapy, reducing peripheral effects of thyroid hormone, supportive care for systemic effects of thyrotoxicosis, and removing or solving the inciting cause. High-dose methimazole can be administered rectally, which can inhibit thyroid production by inhibiting thyroid oxidase. Oral cholecystidine can be administered by conjugated thyroid hormone and facilitate excretion from the interior hepatic circulation. And propranolol is used for a systemic beta blockade effects to reduce cardiac arrhythmia and hypertension, as well as inhibit the enzyme converting T4 to active hormone T3 in peripheral tissue. Glucocorticoids can reduce the peripheral conversion of T4 to T3, as well as treat for possible adrenal insufficiency if that has not been ruled out, as well as providing supportive care for GI signs, hypothermia, and GI upset. A mild hypertension occurs in about 10% in hyperthyroid cats and confers a poor prognosis. Proteinuria is commonly found in hyperthyroid animals and also confers a poor prognosis. The magnitude of proteinuria is associated with the rate of renal failure progression and is considered to have a negative prognostic indicator. Cats with a UPC greater than 0.4 and dogs with a UPC greater than 0.5 have a worse prognosis and shorter survival time than non-proteinuric animals with kidney disease. Arterial thromboembolism can be increased with proteinuria due to renal loss of clotting factor number 7 or antithrombin. And treatment of hypothyroidism can decrease the magnitude of proteinuria. Proteinuria is most commonly due to pre-renal causes, which can increase is due to increased GFR, which increases proteins being filtered that oversaturate the resorptive capacity of the proximal tubule. And this contributes to progression of renal damage by interstitial inflammation and fibrosis around the renal tubules. Regular screening monitoring of hypothyroid animals before, after, and while in the hospital includes going through and regular screening of renal function through BUN, creatinine, USG, and UPC, as well as urine output. That can provide useful information on the development of kidney dysfunction. Blood pressure should be routinely monitored, as and these patients can have a low body fat, so routine monitoring of body temperatures can circumvent the development of hypothermia. Regular recording of body weight can help monitor weight loss for fluid accumulation. And hypothyroidism can also increase the risk of AKI developing under anesthesia due to changes in the GFR leading to renal hypoperfusion. Lipophilic drugs can be metabolized differently due to decreased fat stores, and a urine culture can be helpful to go through and be able to assess for the presence of urinary tract infection or pyelonephritis, as up to 22% of hypothyroid cats can have a positive urine culture. Hypothyroidism occurs commonly in dogs with incidence of 0.2 to 0.8%, and an overrepresented in purebred to middle-aged dogs. It occurs rarely in cats, the most common cause being secondary treatment for hypothyroidism, and rarely is congenital disease. In dogs, lymphocytic thyroidism is a predominant cause, which is an immune-mediated disorder characterized by antibodies interacting with antigens of follicular cell colloids or thyroid globulins that activates the complement cascade and cell-mediated toxicity. The infiltration of lymphocytes, plasma cells, and macrophages in the thyroid gland leads to progressive destruction and secondary fibrosis, resulting in the failure of thyroid hormone production. Idiopathic atrophy is another cause in which the thyroid cells atrophy and are replaced by adipose tissue. These clinical signs of hypothyroidism occurs when approximately 75% of the gland is lost. The pathophysiology of hypothyroidism largely mirrors the opposite of hyperthyroidism. There's a decrease in circulating thyroid hormone, which leads to myocardial hypokinesis, or a decrease in heart rate and contractility, resulting in decreased cardiac output and subsequent hypotension. Absence of thyroid hormone permits an increase in peripheral vascular resistance, which increases cardiac afterload, leading to increased diastolic pressure and decreased systolic pressure. The decreased systolic pressure leads to a decrease in GFR, and the decrease in GFR is further compounded by decreased sensitivity to beta-adrenergic stimulus, blunting the intrarenal vasodilation and renal release, which reduces production of angiotensin II and subsequently decreases RAS activity. In addition, hypothyroid-mediated changes to the glomerulus limits proximal tubular absorption of sodium chloride and water that increases the intratubular concentration of chloride that is sensed by the macula densa and further reduces the RAS activity. Restoration of a euthyroid state can reverse the cardiovascular and renal changes. Clinically, hypothyroidism causes a bradycardia with reduced myocardial contractility, which then leads to a stiffened left ventricle due to reduced cardiac output with decreased heart rate and stroke volume, consistent with diastolic dysfunction. Arrhythmias can also develop, and these cardiac changes are reversible within 60 days of levothyroxine treatment. The decrease in GFR can present on blood work as an increased serum creatinine and theoretically a low USG due to the decrease in urine concentrating, which is found to be reversible within 30 days of treatment. Being aware of the cardiac and the renal changes, although likely reversible with consistent treatment for hypothyroidism, is important in newly diagnosed hypothyroid dogs. It's useful for trailing the anesthetic protocols prior to surgery and modifying drug dosing, as well as monitoring the ICU. More commonly, hypothyroid dogs have dermatological changes, which starts with asymmetrical form located on the thigh, tail, base, or tail. In severe cases, can develop into symmetrical bilateral truncal alopecia. Hyperpigmentation and skin chromosomes can develop. Thyroxine hormone plays a role in initiation and maintenance of the anagen or growing phase of the hair cycle. And reduction of thyroxine hormone results in premature entrance of hair follicles to the telogen phase, that then causes the hair to be lost, leading to excessive shedding and lack of hair regrowth, resulting in alopecia. Generalized alopecia may develop in severe cases of the disease, as thyroid hormones are responsible for the production of proteoglycans in skin, which promote epidermal differentiation by activating fibroblasts and keratinocytes. Superficial pyoderma can develop due to suppression of the immune system and hormone imbalance, and the most common pathogens isolated in hypothyroid dogs with pyoderma include malassezia, pachydermatitis, Demodex penis, and Staphylococcus species. In humans, hypothyroidism is a known risk factor for the development of non-healing wounds, and humans undergoing intravertebral vasectomy and orthopedic surgery, they do have an increased risk for the development of non-healing wounds. And hypothyroid dogs also have an increased incidence of otitis media and interna. About 91% of hypothyroid dogs have hypercholesterolemia on their blood work. These thyroid hormones regulate lipid metabolism by increasing the activity of receptors that promote LDL cholesterol from the blood and arteries to the liver breakdown. And thyroid hormones can stimulate the mobilization of stored triglycerides from adipose tissue and increase the activity of enzymes such as lipoprotein and hepatic lipase that break down lipoproteins. And lack of the thyroid hormone results in increased circulating LDL and HDL, which can accumulate within vessels, causing thromboembolic events, and in severe cases, atherosclerosis that can be seen accumulating within the cerebral vessels, as well as within the heart and also the kidneys. A mild anemia, approximately 30 to 50% of dogs have a mild anemia characterized as a mild normocytic, normochromic, non-regenerative anemia due to lack of thyroid hormone stimulation on bone marrow with erythropoiesis. Less common is a hypochromic microcytic anemia due to reduced iron absorption from the GI tract. These anemias can be exacerbated by fluid administration in the hospital. Also, coagulopathies and prolonged clotting times is not a routine finding, yet the development of hypothyroidism later in life can amass subclinical von Willebrand's disease. The concurrent illnesses can suppress the hypothalamus pituitary axis, or advanced hypothyroidism can develop into spontaneous bleeding. A 7-year-old Shetland sheepdog presented for evaluation of spontaneous epistaxis and was revealed that she had developed hypothyroidism and had mild congenital von Willebrand's factor defect that had exacerbated the lack of thyroid hormone. Lower body temperature is recognized in hypothyroidism due to the blunted effects of thyroid hormone on metabolism, reducing metabolic thermogenesis and reduced cardiac output in concordance with peripheral vasoconstriction, reducing peripheral blood flow. This manifests as a heat-seeking behavior, and these animals are also less likely to have a fever, and they're also cold intolerant, which fortunately can resolve with treatment. About 45–50% of hypothyroid dogs have GI signs, most commonly being constipation or diarrhea, yet regurgitation can also occur. There is an increased risk factor for postoperative ileum and constipation, which can be exacerbated with use for pain management. Neurological deficits are present in approximately 7% of hypothyroid dogs. It can affect the peripheral and central nervous system. The pathological causes underlying these neurological defects are related to alterations in axonal transport, hyaluronic deposits around and depressing nerves, and microvascular changes, secondary arteriosclerosis, and or thromboemboli. Thyroid hormone induces activity of ATPase that's necessary for axonal transport of ATP and molecular proteins. And thyroid hormone also influences the expression of dynin and tubular proteins that are involved in microtubular function necessary for axonal transport. In hypothyroid dogs, nerve conduction velocity is reduced and compound muscle action potentials are also reduced, consistent with abnormal axonal transport, as well as axonal degeneration and impaired regeneration. Other pathophysiological mechanisms include ischemia and myxodematous deposits, and in dogs with central hypothyroidism, the pituitary neoplasias can compress surrounding structures, causing central nervous system signs. This slide is mainly used to go through and demonstrate all the different types of neuropathies that can arise in dogs with hypothyroidism. So peripheral and central neuropathies in hypothyroid dogs can present as muscle weakness, ataxia, vestibular signs, facial paralysis, decreased patellar and withdrawal reflexes, and decreased muscle tone and atrophy. And a generalized polyneuropathy related to abnormal axonal transport, which is characterized by a decrease in motor nerve conduction velocities. This could typically affect large and giant breed dogs, and they can present in clinic as pelvic limb paresis that can progress to tetraparesis. Thrombi may also be present in the femoral iliac arteries, further going through, contributing to their pelvic limb paresis. Myasthenia gravis occurs in 10 to 20% of hypothyroid humans due to cross-reaction of autoantibodies against acetylcholine receptor and self-antigens in thyroid gland. The migration of thyroid gland from the floor to the foregut, where myoepithelial cell expressing acetylcholine can be acquired as the thyroid gland migrates caudally. This can be a cause of regurgitation and megaesophagus during anesthetized procedures and hospitalization. Cranial nerves can also be affected, with the most common being facial nerve paralysis, reported about 70% of the hypothyroid dogs. KCS can also occur. Mixed MSD pots surrounding nerves, they pass through the internal acoustic meatus, can compress the facial nerve and decrease vascular perfusion, leading to absent palpebral and menis reflex. Facial asymmetry and decreased tear production can also be present. Peripheral vestibular disease has been implicated in hypothyroidism, and measuring the total thyroid hormone of similar dogs may be useful. Laryngeal paralysis is also reported, but does not respond to treatment. Myopathies can arise due to abnormal cellular metabolism and present as general weakness, muscle pain, and stiffness, and can involve the respiratory muscles, leading to dyspnea and respiratory acidosis. Central neuropathies can also be present, and they present as mental dullness, circulating seizures, central vestibular signs, and cognitive dysfunction due to arthrosclerosis, myxedemia, coma, and pituitary tumors can also compress the diencephalon and associated reticular activating system, causing mental dullness. Myxedemia coma is a rare, life-threatening, awful, fatal form of severe hypothyroidism. So often hypothyroid dogs can develop a secondary disorder, such as an infection, acute disease, or progressive chronic disease that can overwhelm the normal homeostatic mechanisms and further depress the thyroid hormone. Dogs may present with dullness, myxedemia, or pitting edema of the skin due to accumulation of glycosaminoglycans in the interstitial space, hypothermia, bradycardia, hypotension, or hypoventilation that can progress to stupor and coma. Development of cerebral edema contributes to the mental state of dullness that can progress to coma. The mainstay of treatment is IV synthetic thyroid hormone, such as levothyroxine, that can be given as 5 mg per kg IV every 12 hours, as well as cautious intensive supportive care, which may include ventilation, slow correctional hypothermia to prevent peripheral vasodilation, support of the blood pressure, correction of sodium levels, and additional supportive care is needed. Although hypothyroidism has not been associated with complications, duration of hospitalization, delayed recovery from anesthesia, or death, hypothyroid patients do have specific needs and requirements, such as monitoring temperature and implementing potassium hormone, routine monitoring of blood pressure, applying tear solution as facial nerve paralysis can decrease tear production, leading to the development of corneal ulcers. Administration of drugs that are cleared to kidneys can also have a decreased clearance due to the decrease in GFR in hypothyroid patients, resulting in prolonged effects of those drugs. Weakness of the respiratory muscles can predispose to pneumonia and atelectasis, and the presence of non-regenerative anemia can progress to severity with fluid administration in the hospital. There is a risk of superficial pyoderma developing due to depressed immune function, and monitoring sodium levels as the decreased antidiuretic hormone can predispose to hyponatremia. And also GI signs can present as constipation, and megaesophagus can present as regurgitation. The total T4 should be checked in patients prior to surgery on being admitted to ICU. And appropriate administration of levothyroxine can improve the effects of hypothyroidism within 2 weeks, and adequate clinical response can be achieved within 8 weeks of treatment. Hypoallergenic occurs frequently in dogs and is uncommon in cats. Naturally occurring primary hypoallergenic corticism is the most common cause and occurs when an immune-mediated process destroys 85 to 90% of adrenals, leading to inadequate secretion of mineralocorticoids and or glucocorticoids. Other causes include fungal infiltration, neoplasia, trauma, or cardiopathy. Acute withdrawal of glucocorticoids can also cause iatrogenic secondary hypoallergenic corticism, as exogenous glucocorticoids suppress anterior pituitary secretion of ACTH that suppresses function and growth of the cells, comprising the zona vesiculata and zona reticularis, leading to atrophy and the development of hypocorticism. Naturally occurring secondary hypoallergenic corticism is similar, yet differs as it arises from failure of the pituitary gland to secrete ACTH, which can be caused by neoplasia, inflammation, and head trauma. The adrenal cortex is composed of 3 layers that secrete hormones vital for daily function. The outer layer, the zona glomerulus, synthesizes and secretes mineralocorticoid hormones from cholesterol and supplies precursors to the inner 2 layers. Aldosterone's specific and vital function is to enhance sodium, potassium, and water homeostasis. And insufficient aldosterone can lead to life-threatening hypotension, hyperkalemia, and hyponatremia. The inner layer, zona vesiculata, secretes cortisol, which has an effect on almost every tissue in the body and plays an particularly important role in the regulation of blood pressure, water balance, and vascular volume, metabolism, and increases vascular sensitivity to catecholamines, as well as suppresses the inflammatory responses and stimulates erythrocytosis and counteracts stress. The zona reticularis is the middle layer and secretes androgen sex hormones. Hypoallergenic corticism can be insidious and can cause vague and nonspecific signs at home until an inciting event such as the stress of surgery, boarding, moving, or the development of secondary illnesses overcomes the adrenal gland's current functional ability. Clinical signs observed at home can be vague and nonspecific, the most common being a poor appetite, vomiting, regurgitation, weakness, weight loss, and diarrhea, and can range from mild to profound, depending on the severity of the disease. Patients presenting to the hospital can present bradycardic, hypothermic, with weak femoral pulses. They can be depressed, dehydrated, collapsed, and in shock, have abdominal pain, and have melena and or hematochezia. Diagnostics can reveal a profound hypotension that is marginally responsive to fluid therapy due to fluid loss secondary to GI upset and loss of vasomotor tone due to cortisol deficiency and impaired adrenergic responses to noradrenaline. Dogs in a Addison crisis, they often present weak and lateral recumbency due to profound hypotension. This results from insufficient cortisol production, leading to progressive loss of vasomotor tone and impaired alpha-adrenergic receptor responses, noradrenaline. Blood work in primary hypoallergenic corticism typically reveals hyperkalemia, hyponatremia, hypochloremia, and pre-renal azotemia due to insufficient aldosterone-mediated excretion of potassium and reabsorption of sodium and chloride, with a resulting decreased GFR. Other findings may include a hypophosphatemia, metabolic acidosis, a moderate hypoalbuminemia, mild increase in ALT and AST, secondary to hepatic hypoperfusion, and a mild normocytic, normochromic, non-regenerative anemia. A lack of or a mild stress leukogram in a sick and stressed dog should be a poignant signal to investigate the hypoallergenic cortisone. Eosinophilia can also be present. A low urine or serum cortisol is a strong supportive diagnostic finding of Addison's. Imaging with thoracic radiographs can reveal a microcardia, megaesophagus, and a reduced caudal venal cava size, and abdominal radiographs can reveal microhepatica. Abdominal ultrasound can reveal small adrenal glands, and an ECG can demonstrate the hypokalemic effects on the repolarization potential of cardiomyocytes. Elevated potassium increases the activated potential difference, resulting in increased threshold depolarization that initially causes bradycardia, and as the hyperkalemia progresses, it can lead to a prolonged refractory period, resulting in progressive loss of P waves, peak T waves, and a prolonged Q restoration. The mainstay of treatment for Addisonian crisis resides on fluid therapy and glucocorticoid administration. 0.9% sodium chloride is a thoughtful choice that contains no potassium. However, the large volume of fluids necessitated to restore volume negates the effects of the small amount of potassium within LRS and NORMAR, and the buffers from these fluids can be helpful to buffer acids such as elevated lactate and BUN as well as other unmeasured anions. Glucocorticoid replacement with 0.25 dex-SP can help restore aldosterone and cortisol levels, and treatment for hypokalemia with calcium gluconate, as well as a short-acting insulin, such as insulin R, followed by dextrose CRI, tailored to the volume of insulin administered as well, and also further tailored with careful monitoring of blood glucose and adjusting the dextrose CRI appropriately. As well, and also supportive care for GI signs, treatment for hypothermia, as well as going through and monitoring for anemia. Known Addisons can be prepared for surgery by administering a stress dose of hydrocortisone or prednisone in the perioperative period. One protocol is administering hydrocortisone IV and induction anesthesia, followed by a hydrocortisone CRI into the patient is able to take an oral glucocorticoid, then tapered to an appropriate maintenance dose within 2 to 7 days, depending upon their recovery. Dex-SP is useful as it has anti-vomiting and anti-nausea properties, yet it doesn't have any mineralocorticoid properties, so it restores cortisol, yet not aldosterone. When going through and being able to treat Addisonians, being mindful of drugs that suppress synthesis of ACTH when administered during critical illness includes opioids, antifungals, particularly ketoconazole, and also glucocorticoids due to negative feedback on ACTH and benzodiazepines. So thank you very much for going through and listening. These are my references, and also happy International Cat Day. If you guys have any questions, we'd be more than happy to answer.